This conference will now be recorded.
Hello again, everyone. My name is Viv Marks. I'm still working on my master's through Grand Canyon University, and today I want to talk to you about coronary artery disease. Students should have knowledge of heart anatomy and terminology. This video is made for students in higher education. Coronary artery disease is the leading killer of men and women around the world. It accounts for almost 50% of all deaths. Your genetics may play a role in CAD, so knowing what it is, what the symptoms are, and how your life would be affected by this disease is important. We will begin by defining CAD and listing some symptoms. Next, we will look at the risk factors for CAD. We will discuss treatments, both medicinal and invasive measures, and how to prevent it. Finally, we will discuss the genetics of CAD. Coronary artery disease, or CAD, is a blockage or plug of the coronary artery walls that reduce the amount of blood flow. This affects the amount of oxygen that will be needed to keep pace with the heart. CAD could lead to a myocardial ischemia, a reduction in blood flow, or a myocardial infarction, a heart attack. While this may take decades to form, there are a few ways CAD could happen, either vascular spasm, atherosclerosis, or a thromboembolism. Symptoms of CAD can be acute or chronic. Acute symptoms include a tightness in the chest, dizziness, shortness of breath, generally not feeling very well, and nausea. Chronic symptoms include sweating, shortness of breath, and angina. Angina is a common term for chest pain and can be stable or unstable. Stable angina are chest pains during exercise. Unstable anginas can lead to myocardial infarctions and is ranked based off the level of blockage. We will discuss treatments for CAD on another slide. Vascular spasm, an early stage of CAD, is constriction in the vessels when cold, anxious, or performing physical activity. Since the heart is not getting enough oxygen due to constriction, the lining of the blood vessels, known as the endothelium, releases platelet activating factor. Platelets are cell fragments that promote clotting. In the coronary vessels, platelets will diffuse into the smooth muscle of the heart and cause it to contract or spasm. While this sounds serious, it is the least serious condition and is reversible. Atherosclerosis is a slow developing degenerative disease that leads to the blockages of vessels. Plaque, with its lipid core and collagen cap, develops under the lumen of blood vessels. This usually begins with an inflammatory response to an injury of the blood vessel wall. Though we aren't sure exactly what the factor in the formation of plaque is, oxidized cholesterol, high blood pressure, chemicals from fat cells, bacteria, or viruses may be suspected. Quickly, I would like to discuss cholesterol and its role in CAD. Cholesterol is a type of lipid, one of the basic molecules in the body. They are hydrophobic, meaning they are water-hating. To travel through the bloodstream, they need to be bound to a transport protein. We get cholesterol two ways. First, it's made in the liver, or second, we receive it from our diet. There is good and bad cholesterol. The bad cholesterol, and what is an important factor in CAD, is the low-density lipoproteins, or LDLs. These molecules carry oxidized cholesterol to the cells, including cells in the coronary vessels, which may trigger that inflammatory process which leads to atherosclerosis. A normal LDL level is around 70 milligrams per deciliter. As we age, the concentration of LDLs increasing the risk of CAD. A Mediterranean diet with lots of fruits and vegetables with less focus on red meat and more on seafood is a great way to reduce cholesterol in one's diet. The final factor of CAD is thromboembolism. This is an effect of atherosclerosis, where the plaque ruptures or breaks through the endothelium and can trigger the formation of clots. During a rupture, the collagen-rich innards attract blood platelets and begin clotting the vessel. These clots are called a thrombus. This could completely block the vessel at a site, causing myocardial ischemia or break off. Once broken off from the vessel, the thrombus is known as an embolus. An embolus could plug a smaller vessel known as thromboembolism. CAD ultimately leads to oxygen deprivation of heart cells, leading to a heart attack, often caused by these emboli. Risk factors and the variables for the pooled cohort equation includes age, cholesterol levels, whether a patient has diabetes, is obese or smokes, has blood pressure or hypertension, and what their way of life is. The older we get, the more likely we are to form plaque, have raised cholesterol levels, and elevated blood pressure. No one ages the same, so the factors that may affect one person may not affect you. To determine whether a patient would need to take medications for CAD, we use the pooled cohort equation, which uses the risk factors to determine a percentage. Patients will typically start statin drugs if their 10-year risk is above 7.5%. In the given example, the patient would not be a candidate for statin drugs based off their history, with only a 10-year risk of 1.3%. To dissolve a clot, one may have a thrombolysis completed. To surgically remove a clot, it would be a thrombectomy. To displace a clot or open a vessel, an angioplasty may be done. This process is common, starting with a catheter entered into the artery via a vein in the arm or leg. It guides a wire to the site, expands a balloon that then places a stent. A stent, which is made of fine metal, keeps the artery open for blood flow. A final invasive procedure may be bypass surgery. At this point, the blockages are too severe for stents to be useful. Taking a vein from the legs, the artery is rerouted past the blockage. So, if you are not a fan of having pain in your chest all the time, or even while you are working out, there are things you can do to start early to help prevent CAD from forming. First is a healthy diet, low of cholesterol. Additionally, exercising to get your heart used to pumping and stress. Finally, as we age, we should begin taking baby aspirin to reduce clotting. Based off our genetics and the pooled cohort equation, drugs may be used on a case-by-case basis, including statin drugs to reduce cholesterol, beta blockers to reduce adrenaline on the heart, or ACE inhibitors to decrease blood pressure. Coronary artery disease can be prevented if early on we are mindful of our diet and exercise. Unfortunately, some of us are genetically predisposed to have CAD. This means that one may have an increased risk factor for CAD due to their genes. This includes single gene disorders, which affect a little under 1% of the population. It is claimed so far that of the 8,315 disorders, there have been 5,482 genes found which are responsible for increased CAD formation. For this type of genetic disorder, a familial pedigree going back 2 to 3 generations will be needed. Once the DNA marker has been sequenced and cloned, one may be able to find the mutation. The discovery of familial hypertrophic cardiomyopathy and Wolff-Parkinson-White syndrome has been through genetic testing of a single gene. More commonly, polygenic disorders may be found in 75% of the population. With the mapping of the human genome at the end of the last century, 9p21 genetic risk variant was discovered by multiple independent groups. Except in Africans, this variant is very common. The hypothesis behind this variant is that polygenic disorders are due to multiple commonly occurring alleles. To reiterate, it was the mapping of the human genome that led to the discovery of CAD mutations in genes. Chang, Handley, and Roberts recently published a literature review discussing the need for genetic risk stratification. Since CAD is a slow-growing disease taking years to manifest, it is important that we find a way to categorize groups based on their risk, either high, intermediate, or low. We would not want to treat each patient the same way, as someone with high blood pressure would need an ACE inhibitor rather than a statin, since it is not their cholesterol that needs managed. This is where the pooled cohort equation comes into play, as it uses conventional risk factors to determine whether a patient should start statin drugs. Another interesting point from the article is the belief that over 80% of CAD risk variants may be hidden in the non-coding sequences of our genes. Further studies of DNA sequencing and more samples will be required to get a better picture of CAD risk variants and how they play a familial role. So let's summarize the information that we've discussed today. Coronary artery disease is the blockage of coronary vessels by plaque. Though we aren't sure exactly how plaque is formed, low-density lipoproteins or bad cholesterol may be a factor. CAD includes pain in the chest called angina that can be chronic or acute. When the cells of the heart do not get enough oxygen, parts of the tissue die, leading to a heart attack. Medications based off different factors may be prescribed. More invasive measures like angioplasty or bypass surgery may be required based on the plaque blockage. Our genetics may play a role in whether we are predisposed to having CAD. Exercise and diet are 2 ways that we can reduce our risk of coronary artery disease. Thank you very much for watching. Here's a list of all of my resources, and all of the images that you saw were provided by Google Creative Commons via PowerPoint. Thank you very much.